All right, good afternoon, everyone, and welcome to Citywide Medical Grand Rounds for today, November 27th, with St. Joseph Healthcare Hamilton as the host site. And we'll just progress to the next slide. My name is Dr. Madeline Verhofstadt. I'm a hematologist here at St. Joe's and pleased to be co-hosting the rounds today with Dr. Amanda Huynh in my role as the Chief of Medicine at St. Joe's. Next slide, please. So I will start with a land acknowledgement. We acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. On to our presentation for today. I'm pleased to welcome three wonderful PGY3 teaching medical residents today to speak with us on the topic of timing of anticoagulation after ischemic stroke and atrial fibrillation. So we have Dr. Sebastian Dowhanik, Dr. Mary Shi, and Dr. Kayley Shu. And I'm going to hand things over to Dr. Amanda Huynh to tell us a bit more about our presenters.
So I have the pleasure of introducing our three TMRs. So Dr. Dowhanik is a PGY3 internal medicine resident. He is going to be moving forward to doing a GIM fellowship in Winnipeg next year. Dr. Shi is also a PGY3 internal medicine resident at McMaster, but she also completed her Bachelor's of Medical Sciences at Western University, followed by her MD at the U of T. She's now moving forward to doing her hematology fellowship at the University of Toronto as well. And Dr. Shu is a current PGY3 resident as well at McMaster, and she completed her medical school training at Queen's University and will be going forward to doing her rheumatology training at McMaster next year.
All right, thank you very much, Dr. Verhofstadt and Dr. Huynh for that introduction. My name is Mary, and I'll be starting off our presentation. Just to start with this conflicts of interest slide, we don't have any conflicts of interest to declare. So our objectives for this session are, first of all, to discuss the roles and the risks of anticoagulation after ischemic stroke in atrial fibrillation. Number two, to understand current practices in the timing of anticoagulation after ischemic stroke and atrial fibrillation. And number three, to discuss the findings of a very exciting meta-analysis that was just recently published in The Lancet in July of 2025 called the Catalyst Meta-Analysis and the 4 trials that were included in this meta-analysis, and how these findings might inform future practices regarding anticoagulation after stroke in atrial fibrillation. We hope that this topic can be very of utility to everybody here in general internal medicine and in other specialties. All right, so we'll start off with a case that might be familiar to many of the audience here. You're seeing a 75-year-old male with hypertension, dyslipidemia, and type 2 diabetes presenting to the ED with an acute onset left-sided facial droop and left-sided weakness that began 3 hours before arrival. On your examination, his NIHSS score is 10. A CT head without contrast showed no intracranial hemorrhage. He is considered a candidate for thrombolysis, and he is thrombolysed with TPA IV at a standard dose of 0.9 milligrams per kilogram. Post-thrombolysis, he has an improvement in his NIHSS score from 10 to 7 over the next 3 hours. 24 hours post-TPA, an MRI shows a moderate acute right-sided MCA infarct with no hemorrhagic transformation. You do an ECG as part of your workup for the etiology of stroke, and you see that the ECG shows a new diagnosis of atrial fibrillation. So our question that we would like you to keep in mind throughout our talk is, in this patient with a moderate ischemic stroke or any ischemic stroke with new atrial fibrillation, when should anticoagulation with a DOAC be started? So, in terms of stroke and atrial fibrillation, we know that atrial fibrillation is a very common etiology of ischemic stroke, and it actually comprises about 20 to 30% of known ischemic strokes. We also know that stroke patients with atrial fibrillation actually have higher rates of stroke severity and mortality. Over the last decade, and actually over the last 20 years or so, there have been numerous pivotal trials that were published between the years of 2009 and 2013, particularly studying the use of DOACs in atrial fibrillation. Particularly, these studies were the RELY study for dabigatran, ENGAGE AF TIMI for edoxaban, ROCKET AF for rivaroxaban, and Aristotle for apixaban. And all of these pivotal trials compared these DOACs with the use of warfarin for secondary prevention of ischemic stroke in atrial fibrillation. And a Lancet meta-analysis by Ruff and colleagues in 2014 actually examined these studies together and found that DOACs reduced stroke and systemic embolic events by about 19% compared to warfarin. And in addition to that, DOACs also reduced all-cause mortality and intracranial hemorrhage. So these pivotal DOAC trials were quite practice-changing, as was that meta-analysis I had mentioned. However, one thing to note about these DOAC trials is that they actually excluded participants with recent ischemic stroke, particularly between the interval of 7 to 30 days prior to randomization. The RELY and ROCKET AF trial excluded any stroke in the past 14 days. Aristotle excluded past stroke in the prior 7 days, and ENGAGE AF excluded any stroke in the past 30 days. Thus, this has raised a critical question for all of us internists and neurologists, which is, what is the actual optimal timing of starting anticoagulation after ischemic stroke? And to this day, well, up until recently, it remained pretty unclear. Early DOAC initiation can supposedly reduce the risk of early stroke recurrence, but at the same time, we have to balance this with the risk of hemorrhagic transformation. And we know that the risks of both recurrent ischemic stroke and intracranial hemorrhage are highest in the first few days after acute ischemic stroke. I would like to bring your attention to a stroke scale that we are likely all familiar with, which is the National Institutes of Health Stroke Scale, or the NIHSS. This is a very commonly used and standardized stroke scale using a 15-item scale that is actually intended to evaluate stroke severity as well as stroke-related neurological deficit. We know that the NIHSS score can also predict both long and short-term outcomes in people with stroke. So items that you can see on this scale here are, for example, level of consciousness, extraocular movements, visual fields, facial muscle function, extremity strength, sensory function, coordination, language, speech, and hemi-inattention. And this will come into play later on in our talk when we discuss how we stratify patients on stroke severity based on their NIHSS score. So, what do international guidelines currently say about timing of anticoagulation after stroke with atrial fibrillation? International guidelines actually do vary, but kind of are tied together by a very common rule. And one thing to note before I talk about that rule is that these international guidelines are largely based on consensus rather than prospective data. And several of these guidelines were also developed in the age of basically vitamin K antagonists or warfarin, and are less updated in the age of DOACs. So a very common rule used by many countries, including the European Society of Cardiology and the Canadian Stroke Best Practices, is called the 1-3-6-12 rule. And basically this rule stratifies recommended timing of anticoagulation start based on the severity of stroke. It says that for transient ischemic attacks, starting day 1 post-stroke is reasonable, whereas for mild stroke, which is classified as NIHSS less than 8, a day 3 start is reasonable. For moderate strokes or NIHSS score of 8 to 15, day 6 is appropriate. And for severe strokes or NIHSS of over 16, greater or over 16, a day 12 start is appropriate. And what this rule does assume is that the risk of hemorrhagic transformation is related to the size of the infarct. And therefore, the larger the infarct, the longer we should be waiting before starting anticoagulation. The American Heart Association and the Canadian Stroke Best Practices Guidelines actually make a special statement as well, in addition to the above, saying that in folks who have a high risk of hemorrhagic transformation, such as severe stroke syndromes and large infarcts, we can delay anticoagulation for up to 2 weeks or more if that risk of hemorrhagic transformation is considered high. And like I had mentioned, these guidelines were developed during the era of vitamin K antagonists, such as warfarin. So I would like to bring your attention to the European Society of Cardiology guidelines that kind of hammer home this 13612 rule. Based on the NIHSS score. I would like to highlight 2 things about this diagram. First of all, the European Society of Cardiology guidelines also incorporates other factors that should be considered for early and late start of DOAC. So for example, here in this highlighted box, you can see things that favor early start of DOAC might be neuroimaging criteria, with such as small or no brain infarction on imaging, high recurrence risks such as cardiac thrombus on echo, young patients who are clinically stable with well-controlled BP. Whereas high risk factors that might favor delayed start of DOAC might include moderate to large brain infarct on imaging, need for carotid surgery or feeding tube, neurologically unstable patients, elderly, and also uncorrected hypertension. For moderate to severe strokes, the ESC guidelines actually do explicitly recommend repeat imaging with CT or MRI on day 6 for moderate strokes or day 12 for major strokes prior to initiation of a DOAC. Next, I will highlight also the Canadian Stroke Best Practices. These are straight from the guidelines. So you can see here that explicitly stated there is a lack of randomized evidence to guide specific timing, and these guidelines are based on expert consensus rather than prospective data. Bringing in that 13612 rule, TIA, start on day 1 post-TIA. For mild strokes, start on day 3 post-stroke. For moderate strokes, start on days 6 to 7. And for severe clinical strokes with large functional neurologic impact or large size infarcts on imaging, anticoagulation can be started 12 to 14 days post-stroke. And like I had mentioned, the Canadian Stroke Practice Guidelines do make this special statement that if anticoagulation is delayed beyond 24 hours, it's recommended to obtain repeat brain imaging prior to starting anticoagulation. And in addition to that, for those who are high risk of ICH, it's reasonable to wait 2 weeks or more for starting anticoagulation. So getting on to the exciting part of our talk, we would like to bring your attention to a few very exciting trials that were done within the last 3 years or so between 2022 and present. There have been 4 important randomized clinical trials evaluating the timing of anticoagulation start after ischemic stroke. And those are the timing trial in 2022, ELAN in 2023, Optimus in 2024, and START in 2025, which was a phase 2 trial. Most recently, in July of 2025, the Catalyst meta-analysis was published in The Lancet, and we will discuss this meta-analysis as well as these trials in more detail to kind of tie all of this data together. For the next part of the talk, I will hand it over to my colleague Kayley to discuss these trials in more detail.
Thanks so much, Mary. So before diving into the combined Catalyst meta-analysis results, let's first review the underlying evidence base that we're drawing from with respect to the 4 trials as Mary had mentioned. All 4 of these pivotal RCTs were focused on answering the same clinical question, which is when should we start a DOAC after an acute ischemic stroke in a patient with atrial fibrillation? There were some key features and differences in terms of the study designs. For the timing study that was done in 2022, this was the first landmark RCT addressing this clinical question. It was registry-based, multi-center, open label, and a non-inferiority RCT conducted out of Sweden. Patients were randomized 1-to-1 to either an early DOAC start group versus a delayed DOAC start group with blinded outcome assessment. Next, ELON, the RCT that was published in 2023, was an international, multi-center, open label, and assessor blinded RCT. The main unique aspect of this study design was that randomization was stratified in terms of infarct size, minor, moderate, or major, defined as in terms of imaging, which we'll review a little bit later in the slides to come. There were also specific timing windows that were defined for early versus late DOAC initiation based on the size of the infarct on imaging. The outcomes were centrally adjudicated in a blinded manner, and it's important to note that ELON provided valuable estimates of risk, but wasn't designed to make any formal claims regarding superiority or non-inferiority due to its estimation-based design and lack of pre-specified hypothesis testing. Next, with respect to Optimus, which is the RCT published in 2024, this is a multi-center, open-label, blinded endpoint phase 4 RCT that was conducted in the UK. Patients were randomized 1-to-1 to either a early or delayed DOAC initiation group, and the outcome adjudication was performed by a masked independent committee. And the trial used a hierarchical non-inferiority superiority gatekeeper design in the statistical analysis. This means that it first tested for non-inferiority of the early DOAC start group compared to the late DOAC start group, and only if non-inferiority was established, it went on to test for superiority. Finally, START was published in 2025 as a multi-center, smaller phase 2 study out of Texas. Instead of an early group versus a delayed group like the other 3 RCTs mentioned, START actually tested several specific start times to try to answer the question of when is the ideal time to start anticoagulation with more granularity. So patients were randomized to one of 4 different DOAC start time groups, with randomization adapting and changing over time to try to favor the groups that were predicted to have better outcomes, which is a unique response adaptive form of randomization that we'll discuss a little bit further later too. In terms of the scale and recruitment of these 4 RCTs, timing was conducted entirely in Sweden and enrolled just under 900 patients. Meanwhile, ELON was international, although most participants were recruited either from Central Europe or the UK and included a little over 2,000 patients. Optimus was the largest of the 4 RCTs, with more than 3,600 patients recruited from across the UK. And finally, START was the smallest, which enrolled 200 patients in a single US region of Texas. An important difference to note in terms of the inclusion and exclusion criteria of these 4 studies was that 3 of the 4 trials, namely Timing, Optimus, and START, included patients on prior anticoagulation, whereas ELON excluded these patients unless they were on subtherapeutic anticoagulation or if they had documented non-adherence to their regimen. With respect to their treatment of moderate to severe strokes and inclusion of these patients, although Timing had a relatively broad inclusion criteria, its published mean and median NIHSS suggested that most patients had mild to moderate deficits, with the median NIHSS being 4 and the mean being 6.1. ELON, like we will talk about later, stratified based on the severity of stroke on imaging, either CT or MRI. Optimus, despite explicitly allowing a wide range of stroke severities, even those who had minor hemorrhagic transformation, also had a median NIHSS at randomization of 4, with an interquartile range between 2 and 7, which suggested that the majority of these patients were mild to moderate stroke severity. And finally, START had a median NIHSS score at presentation of 6.5, with the median lesion diameter on imaging at the time of randomization of 3.1 centimeters. So together, these trials give us study populations across different countries and healthcare systems, including different stroke severities and with certain practical considerations, for example, being on prior anticoagulation, which are important to consider as we think about DOAC initiation in our own patients and how this would apply to our own patients. With respect to how they defined early versus late DOAC initiation, this was also slightly different between the 4 studies. Timing defined early DOAC initiation as within 4 days of the stroke, whereas delayed was between 5 to 10 days. Meanwhile, Elon stratified this timing based on the imaging severity of the stroke. Minor stroke was considered to have an early DOAC initiation if it was started within 48 hours, whereas late would be day 3 to 4. A moderate stroke would likewise have an early duration of starting within 48 hours, but the window for a later start would be day 6 to 7. And finally, for a major stroke, an early start would be day 6 to 7 versus the late start group was between days 12 to 14. The definitions for severity of stroke by Elon on imaging, so either CT or MRI, are also included on the slide, with a minor stroke defined as something that's less than or equal to 1.5 centimeters on imaging, moderate being an infarct in the distribution of the cortical superficial branch of the middle, anterior, or posterior cerebral arteries, and a major stroke being a larger infarct in distribution of the aforementioned arteries, or a brain stem or cerebellar infarct that was greater than or equal to 1.5 centimeters. Next, to discuss Optimus, the early start group was within 4 days, and the late start group was between 7 to 14 days. And finally, the START trial was the major outlier among the 4 RCTs, where they evaluated multiple specific start times. The first group, the earliest group, was day 3 to 4. The second group was day 6. The third group was day 10, and the fourth group was day 14. They combined risk of ischemic and hemorrhagic events into a single unitless utility score and used this to help model the predicted outcomes using Bayesian statistics. And modeling information from earlier groups also influenced the modeling of later groups in the process of dynamic modeling. The randomization initially began as 1 to 1 to 1 to 1 among the 4 groups, but it adapted over time to favor the groups that look to have better outcomes. Next, this slide shows the different composite outcomes that each trial used as their primary outcome. It's important to note that although each trial used a slightly different composite primary outcome, all of them did use a composite as their primary outcome. The outcome window also varied a bit, with Elon and START using 30 days, while Timing and Optimus used 90 days. Timing ultimately assessed a 90-day composite of recurrent ischemic stroke, symptomatic ICH, or all-cause mortality. Elon at 30 days used a composite including vascular death, recurrent stroke, systemic embolism, major extracranial bleeding, and symptomatic ICH. Optimus used a 90-day composite of recurrent ischemic stroke, symptomatic ICH, unclassifiable stroke, or systemic embolism. And finally, START used a 30-day composite of ischemic events defined as stroke or systemic embolism, or hemorrhagic events defined as symptomatic ICH or major systemic bleeding. Next, we'll discuss the key results and conclusions of each individual study. First, in Timing, the early DOAC initiation group was found to have non-inferior outcomes in terms of the primary outcome compared to the late start group. Event rates were fairly low in both groups and similar. So 6.9% of the primary outcome in the early group versus 8.7% in the delayed group. The absolute risk difference was minus 1.8%, with a 95% confidence interval ranging from minus 5.3% to positive 1.7%, which stayed within the trial's pre-specified non-inferiority margin of 3%. And the p-value for non-inferiority is reported on the slide. Next, we'll discuss the Elon trial. And again, recall that Elon wasn't designed for superiority or non-inferiority statements, but rather for estimates of risk. And this is because of its estimation-based design with lack of pre-specified hypothesis testing. The 30-day composite outcome occurred in 2.9% of the early start group versus 4.1% of the delayed start group, with the odds ratio being 0.7, with the 95% confidence interval ranging from 0.44 to 1.14. And although the point estimate favors an early start, the confidence interval crosses 1, and the trial was not designed to make any conclusions regarding superiority or non-inferiority. Next, in Optimus, the early DOAC initiation group was found to be non-inferior but not superior to the delayed DOAC start group in terms of the composite outcome of recurrent stroke, embolism, and symptomatic ICH at 90 days. The Event rate was 3.3% in both the early and the delayed groups, with 59 events in each group. The adjusted risk difference was 0, with a 95% confidence interval ranging from minus 1.1% to positive 1.2%, which fell well inside the predefined non-inferiority margin established by the investigators of 2%. The P non-inferiority was 0.0003. Meaning that the trial demonstrated non-inferiority, but the P superiority was 0.96. So in short, the early start group was found to be non-inferior, but not superior to a delayed start group in Optimus. And finally, in START, recall that the adaptive randomization was done with a calculation of the utility score. And this utility score was also used to define the trial success criteria. And this is when a group would be selected as having the optimal timing for treatment initiation if the posterior probability that the group was optimal based on the utility score was greater than 0.75. Ultimately, none of the groups met this threshold, but group 1 had the highest probability when they calculated the posterior probabilities of groups 1, 2, 4. Ultimately, the authors concluded that there was no clear optimal start day identified, but based on the probability scores calculated and also the event rates in which group 1 had the fewest events with respect to the primary composite outcome, there was a signal favored towards an earlier start. And group 1 correlated with day 3 to 4 initiation of DOAC. Finally, here's a summary slide summarizing what we just discussed in the key features of each of the 4 RCTs, including how each trial defined the timing, how they defined their primary outcome, the sample size that they were studying, the result as reported in the form of the event rates of the primary outcome in the groups compared, and then some key notes on the unique study design features. I'll now pass along to Sebastian to discuss the Catalyst meta-analysis to further see how we put all of this data together.
Thank you, Kayley. So yeah, that brings us to the Catalyst meta-analysis, which was published this summer in July. So the Catalyst's primary goal was to kind of answer the question that we've been talking about already, whether or not earlier anticoagulation is better than later anticoagulation in people who have had an ischemic stroke. They used their cutoffs of 4 days for early and late, and their primary outcome was a composite of recurrent ischemic stroke, symptomatic intracranial hemorrhage, or unclassified stroke at 30 days. Their secondary outcomes looked at the individual components of the above at 30 and 90 days, and then they also included mortality and then clinically significant bleeding. As mentioned before, they defined early as within 4 days and late as greater than 5 days. So if you recall, the Elon trial, within the minor stroke group, they all would have been technically gotten the anticoagulation in the early groups. They had to exclude these people. And for the major strokes in that group, they all would have been in the late group. So they excluded the minor and major strokes from the Elon trial. The way they ran their meta-analysis was they used something called a one-stage individual patient data meta-analysis, which is not the usual way that meta-analyses are run. But basically, to explain what this means is they took all of the individual raw data from the trials themselves and then ran the numbers as though it was like one big trial, as opposed to most meta-analyses, which usually take all of the trials separately and their estimates and then combine them to come up with a meta-analysis. And the reason they did this were 2 main reasons. One was that the event rate was so low. And so in this case, an individual patient data meta-analysis is preferred. And they had access to it because the people who did the meta-analysis were the people who did all of the other 4 trials. As a result of there only being 4 trials included in this meta-analysis, they weren't able to quantify any heterogeneity. And let's get into the results. So for the baseline characteristics, I'll just give you the long story short that they were similar across the groups that they presented. I do want to bring your attention to the NIHSS scores. The median scores were quite low, so 6, 5, and 5, which would be considered minor strokes. However, when you compare these numbers to population analyses, this is what is representative of the population in terms of the stroke severity. The mild and moderate group, which technically would be minor strokes by the NIHSS cutoff of 8 made up 75% of the population, whereas the severe or major group made up about 25% of the population. They also took a look at, whether or not they got thrombectomy, thrombolysis, or any reperfusion treatment, if they were already on anticoagulation or not. And then you can see at the bottom the trials they included and the population of those trials. So Optimus, being the biggest trial, made up the greatest proportion of this meta-analysis at 66%. Here are the results, but I'll deep dive into these over the next few slides. So for their primary outcome, which took a look at recurrent ischemic stroke, symptomatic intracerebral hemorrhage, or unclassified stroke at 30 days, there was less events in the early group compared to the late group, with an absolute risk difference of 0.9% and an odds ratio of 0.7 with a significant P statistic. So overall, the trial was positive. It suggests that earlier anticoagulation was indeed better than later starting for anticoagulation at 30 days. Taking a look at the primary outcome at 90 days, the earlier group had a couple more strokes. So they went up from 2.12% to 3.1% of the population. There was an increase in strokes in the late group as well, from 3.02% to 3.51%. The odds ratio still tended to favor early. However, the confidence intervals overlapped over 1, and the p-value is no longer significant. So overall, still there's a favor for the earlier initiation, but it no longer became significant. If that true value ended up being 1.19 odds of increased harm, that would correlate to about a 0.6% increase of risk, which is tiny. Taking a look specifically at the recurrent ischemic stroke risk, at 30 days, it was 1.68 in the early group, 2.55% late, and that was a statistically significant reduction with the point estimate at a 33% reduction. At 90 days, statistical significance was lost, but still tended to favor the early group, with the point estimate being a 15% odds reduction in that event. Once again, very low event rate. Absolute risk reduction at 30 days was 0.8%, and at 90 days was 0.45%. Looking at their major side effect for the trial was whether or not there was major hemorrhages. At 30 days, which was defined by symptomatic intracerebral hemorrhage or major extracranial hemorrhage, there was no difference between the early or the late group, with very wide confidence interval, as the event was very rare. And at 90 days, they only looked at just whether or not people had symptomatic intracranial hemorrhages. And once again, there was no difference between the early initiation group and the late initiation group with regards to their symptomatic intracranial hemorrhage risk. Taking a look at mortality, similar to the hemorrhage risk, there was no significant difference between the two groups with regards to their mortality at 30 days or at 90 days. These are the forest plot of the subgroups of interest. When they took a look at NIHSS score, whether or not people got reperfusion treatment, if they were already on anticoagulation, sex, and age. All of the point estimates favor early initiation of DOAC over later initiation of DOAC. And you could see the confidence intervals for like the moderate and severe strokes, or the NIHSS score of like what would be like 15 and above, are quite wide, because they didn't have a lot of these people in the population of the trials that were included. So, conclusions from the CATALYST trial. Overall, there seems to be a favor for earlier initiation of anticoagulation. It reduced the primary outcome of recurrent ischemic strokes and symptomatic intracerebral hemorrhage at 30 days, with the confidence interval being 0.5 to 0.98%. It didn't significantly increase bleeding risk, with a wide kind of overlapping odds ratio of 0.51 to 1.6. The strengths of the CATALYST trial: it's a large, high-quality data set from studies that were published in high-quality journals. the fact that they use an individual patient data, like the way that they ran their meta-analysis, allows for robust subgroup analyses. And the outcomes they chose, recurrent ischemic stroke and like essentially intracerebral hemorrhage, were good outcomes to choose with regards to taking a look at the efficacy of these interventions and the safety of them. Some of the limitations: there was an underrepresentation of patients with moderate to severe strokes. However, when you compare the median or mean NIHSS score of the CATALYST trial, it's similar to what population analyses have. Very, very low event rates. So nearly all of the individual trials, when they ran their statistics over how many people to include in their trials, they way underestimated the number they needed to include, because they way overestimated how many event rates were going to happen. So the fact that they had very low event rates just makes it harder to, detect meaningful differences. As mentioned, when Kayley kind of went over the different trials, most were done either in the UK, Central Europe, Sweden, or USA. So there's an underrepresentation generally of non-Caucasian people. And they didn't assess functional outcomes. They looked at recurrent ischemic stroke risk or bleeding, but whether or not those risks are equal, I guess is kind of up to the physician / or the patient themselves, and kind of how severe their disabilities were from both. So did the CATALYST trial change anything? So if we recall from the introduction, there was the 1-3-6 12-day rule, where minor stroke was considered NIHSS of less than 8, 8 to 15 was moderate, and major was greater than 16, and 1 was for TIA, and then minor, moderate, major for 3, 6, and 12 respectively. So for minor strokes, the CATALYST trial didn't really change the recommendation. It was already to wait 3 days. Most people got their anticoagulation in the early group on the 3rd day. But now we have good evidence to support that recommendation. So we can likely upgrade that recommendation, which currently in the guidelines is just as an expert consensus, to a well-supported evidence-based recommendation that it's likely beneficial to start people earlier on anticoagulation, and I would use 3 days as that kind of sweet spot if they have a minor stroke. Now, what about moderate and severe strokes? Less certain here. The previous recommendation, if you recall, was to wait 6 and 12 days respectively. That's probably too long, based on what we see in the CATALYST meta-analysis. But only 25% of the population in the CATALYST trial had an NIHSS of greater than 10. When they ran their analysis to see if there was any interaction of the subgroups, there wasn't when it came to NIHSS score and DOAC initiation, suggesting that earlier is still better than later. But their estimates overlapped 1. However, the point estimate was in favor of earlier than later, as you could see there from the odds ratio of 0.75 and 0.55. So when it comes to moderate and severe strokes, our interpretation, starting anticoagulation earlier in moderate and severe strokes is probably at least as safe as starting it later, but certainly more data is required to be more certain. So to summarize everything kind of for the general internist, in minor and low moderate strokes, earlier initiation of anticoagulation is safe and better at preventing recurrent ischemic strokes than later initiation. In high, moderate, and major strokes, earlier initiation is probably at least as safe, with the possibility of being better. Overall, the recurrent stroke rate was so low, it's less than 3%, and symptomatic intracerebral hemorrhage and hemorrhagic transformation was rare, less than 1%. Kind of underscoring the efficacy and safety of DOACs in these populations. And, people can have other reasons for being on a DOAC. And so it's really nice to see that these are quite safe drugs to use. And then to keep in mind, always consider the patient. Everyone is different. They're all going to have increased or differences in their baseline stroke risk based on their CHA2DS2-VASc score, their bleeding risk. Consider the infarct size and use imaging to help with your decision making before initiating anticoagulation. And always, it's still advised to have neurology input, especially when there's moderate or major strokes where the data is a little less clear. So revisiting the case where we lysed the patient who came in with an MCA stroke, After they got lysed and there's no bleed a day after on a CT head, you could start them on aspirin. And then because this was a relatively like low moderate stroke based on the NIHSS score, you could do a CT head on day 3 to confirm that there hasn't been any significant bleed, stop your aspirin, and you can start a DOAC. That is our presentation. I'd like to thank everyone for their time and for listening, and a special thanks to Dr. Bell for agreeing to be our supervisor.
Wonderful. Thank you all so much. Big round of applause from the virtual audience here. Thank you for pulling together such a comprehensive review on this important topic. I will invite all of our attendees here in case you have any questions. You have 3 options. You can type them into the chat or into the Q&A, or if you'd like to ask your question, you can raise your hand and we'll put you in queue and give you the opportunity to unmute. And as we wait for some questions to come through, I was just going to start things off. Are you surprised with the outcome of the Catalyst study? And then also just what would you see in terms of the priorities being for further researching this area at this point with the evidence we have in place?
Yeah. Did you want?
I'm happy to answer this one. So I don't think we're that surprised. Like I said, like when it came to like the people seem to already kind of have the sense that like when it comes to minor strokes and like low moderate strokes, it's probably safe to start it earlier. So that was kind of the group consensus based on some observational trials. So it was nice now that we have some really good randomized controlled data to support that recommendation. So I think the most surprising part, and I think kind of all the individual trials talked about this in their discussions, was just how low the event rates were. They weren't expecting like so little recurrent strokes. They weren't expecting so like few major bleeds. So it made it kind of challenging to make with the individual trials a strong conclusion about that. But I think that's just like underscoring how much better DOACs are than like, you know, vitamin K antagonist or warfarin. Like we're in a completely different era when it comes to stroke care and like bleeding risk with the DOACs. With regards to future research, I think kind of mentioned we're still not totally certain about the moderate to severe strokes. I think like when we see patients with that, that's where like neurology or stroke neurology input would be helpful kind of before making decisions. Getting imaging before you initiate anticoagulation would be important in making those decisions. And I think the challenge with coming up with a trial specifically looking at these populations is just that they're rare. Like the median NIHSS score for the general population when it comes to strokes is between like that 5 to 6 mark. So there's not a lot of people to look at this. Perhaps in the future, as more and more people get started on DOACs and maybe earlier than we normally would in the past, there can be some retrospective analyses that like look at whether or not, you know, these people with bigger strokes are actually bleeding more, in which case we would have to revisit, you know, the timing. And I think there are a few new trials going on in China right now that are looking more at like timing as a continuous variable rather than like this dichotomous variable or binary variable where it's like 4 days and earlier or 5 days and later.
And I will also add that I think that one of the outcomes that it was discussed in the Catalyst trial as well was the functional outcomes, which are arguably the outcomes that patients care about the most, which is, can they continue to speak? Can they continue to walk and do everything that they love to do in their life? So I think that's another area of investigation that is a big potential for the future, and one that is arguably of one of the most important to patients.
Yeah, really, really excellent point. Thank you both for those thoughtful responses and reflections. I am going to hand things over to Dr. Nguyen. There's one question in the chat, which she can read out to you, and then if she has any further questions or comments as well.
Perfect. I apologize. I can't tell who the question is from, but there's a question that says, could these results be extrapolated to warfarin start, where DOACs could not be used?
Mm-hmm. Oh, I could start.
You.
I'll give it a stab, but no, I think that's a great question because as we know, there are many patients who are high risk for stroke who are from a population, are contraindicated or in which VKAs are indicated. And so I think that it would be quite difficult and probably not advisable to extrapolate the results and from this meta-analysis in these trials for the reasons being the inclusion and exclusion criteria. So as we had discussed, 3 out of 4 trials had included patients who were on prior anticoagulation, but one of them, the Optimus or the Elon trial, excluded patients who were already on prior anticoagulation, in which case many patients who have indications for warfarin are already on warfarin prior to the event of their ischemic stroke. And in addition to that, looking into the specific warfarin-specific exclusion criteria, the STAR trial, I do believe, explicitly stated that the Optimus trial explicitly excluded patients who were on VKA with an INR of over 1.7, which would include many of our patients which would have a target INR higher than that. So I would be very cautious about extrapolating the results from this trial or this meta-analysis. And in addition to that, considering that warfarin has an inherently different bleeding profile compared to DOACs and have a different onset of action as well as duration of action. And so it's very difficult to kind of extrapolate that bleeding risk. Sebastian, do you have anything to add?
No, that's great.
Yeah.
Okay, great. Thank you for that thoughtful answer. Is there any other questions? Feel free to comment in the Q&A or the chat or raise your hand. Okay. Oh, there's one from Dr. Schulman. Maybe a comment. So it says, with all the experience we have, one can say that warfarin can be started about 3 days before a DOAC because it takes at least 3 days to take effect.
Thank you very much, Dr. Schulman, for that.
No. Important consideration and excellent to have such expertise in the audience. So while the considerations about bleeding, relative balance of bleeding risk and thrombotic risk are going to be different with the DOACs versus warfarin, there is always that lag time before the warfarin anticoagulant effect. Excellent. So I think if there are no other questions or comments from the audience, we can once again thank our presenters who have put an immense amount of time into preparing these rounds. And thank Dr. Huynh for co-moderating, Dr. Bell for supporting our presenters in pulling together an excellent presentation. And thank you all for joining. This concludes our rounds for today. Rounds will be back next Thursday at noon, so please keep an eye on your inboxes for further details and have a wonderful rest of your day and week ahead.